Fighting Blindness Canada's Viewpoint is a virtual education series that brings you the latest in vision research presented by health experts from across Canada. The webinar you're about to watch is a recording. To learn more about the research we fund and upcoming webinars and events, please visit our website at fightingblindness.ca. This Viewpoint webinar is proudly presented by Bayer and supported by Abbvie, Apellis, Beacon Therapeutics, Janssen, MeriaGTx, Novartis, and Roche. Thank you for watching. We hope you enjoyed this webinar and share your thoughts with us in the comment section below. So I'm here with Dr. Sivachandran, and we're going to be doing a little bit differently this session. I'm going to kick things off with a few sort of basic questions just to set the stage about AMD, and then we're going to look to the audience for your questions. And we have a mic, we can bring it around to you, so we'll let you know when it's time to have questions. So I'm very pleased to introduce Dr. Sivachandran. She is a trained retina specialist here in the Toronto Retina Institute. She completed and obtained her PhD and her MD at the University of Toronto, and additional training at McMaster University and the University of Ottawa. She's an expert in complicated cataracts, as well as being skilled in molecular biology, design, and execution of scientific projects. Dr. Sivachandran is passionate about novel treatment approaches and drug targets that will optimize vision and quality of life. All right, so I'm going to turn the podium over to you.
Thank you so much for having me this morning. I'm very humbled to be here and excited. I think knowledge is power, so it's so important for us as a community to interact, engage, and improve our knowledge base so that we can all get the best out of our life and our vision so we can enjoy life. So I'm happy to take any questions.
Fantastic. Well, why don't we start off just to set the scene? Can you tell us what is AMD? What are these wet and dry forms of AMD?
Absolutely. I'm happy to start the basics of macular degeneration. So it's, as it stands, it's age-related macular degeneration. So age is the biggest risk factor. As we, what I call, get wiser in life, things change. Our hairs change, our skin changes, so does our biology. So the retina itself, our cells get what I call a little bit weaker. So the RPE cells in the retina, so you have your retina, which is your, it's an extension of brain tissue, and the foundation for that brain tissue is the RPE cells. So in the select patient with the right genetic predisposition, perhaps environmental risk factors, inflammation, what happens is the cells get weaker. So they can't pump out the waste as well as they would have when you were 20 and 30 and 40. So what happens is underneath the retina, you get waste material that start to accumulate. That's what we call drusen. With drusen, with more inflammation, that starts to distort the retina. That's the hallmark of dry macular degeneration. So it's, one of the doctors used a very good analogy. It's like the garbage trucks don't come to pick up the garbage bags anymore. So all the garbage bags are accumulating and distorting the retina. And so now it becomes toxic to the retina and the RPE cells. The RPE cells start clumping, forming pigments. And then so the dry macular degeneration just progresses slowly over time. And then what happens every year, you have, once you start affecting the anatomy of the retina, now there's a risk for new blood vessels to grow from below, which is the choroid, grow into the retina, and they can bleed, causing a rapid drop in vision. All of a sudden, you wake up one day and you're like, I can't see. This is weird. And then you go and then they check and say, oh, you have wet macular degeneration. You've grown vessels that are bleeding and leaking fluid into the retina. So there's the dry, which we talked about, and there's the wet macular degeneration. So every year, for those who have a dry macular degeneration, there's a 10% risk of developing the wet macular degeneration form. If that wasn't clear, please put your hand up. I'm more than happy to elaborate more.
Could we talk a little bit about what treatments are
think she had a question.
Is there a way that you can reduce the waste?
Absolutely. So there are things that we can do to slow down the waste accumulation. So that's one aspect. That's the whole aspect of lifestyle modification. What we eat, what we consume, what kind of environment we're in, all that matters, right? And so foods that are rich in antioxidant, anti-inflammatory are very good. So it's typically recommended like a Mediterranean type diet, lots of berries, good fats, avocado, fish, fatty fish, good fat is very important. Dark green leafy vegetables are also recommended. And then other things that you can do in terms of life is improving your cardiovascular risk factor. So if you have high blood pressure, if you have diabetes, if you have heart disease, trying to improve all those things because we know that causes inflammation. Reducing and optimizing that is important. So there's the diet, there's the medical conditions, and then the social factors that we can optimize. So if you're a smoker, we know smoking causes inflammation to our blood vessels, right? If you are a smoker, then I always say, okay, I'm not gonna ask you to stop cold turkey, but let's work on cutting it down and eventually with the goal of stopping. So then I connect them to also their family doctor who can step in and provide, because these are habitual things that are hard to just stop. So we all need help, right? So there's special programs in place that can help you get rid of those, slow it down. So, and then alcohol consumption. Again, it affects various parts of your body, including inflammation. So I always say cut that down. So we talked about, and then there's, the genetic. What our parents gave us is what our parents gave us. We can't change that. And then there is supplementation that you can also do. So supplementation, we can get into the age-related eye disease studies. So the ARIDS group did prospective randomized placebo-controlled trials looking at a specific group of vitamin supplementation to reduce the risk of progression of the macular degeneration to the advanced stage. So ARIDS-2 is the now recommended vitamin supplementation that has a combination of vitamin C, E, lutein, zeaxanthin, as well as zinc. So that's what I recommend for my patients as well when I see patients with dry macular degeneration. So I talk about all those things, and then you specifically asked about, can we get rid of those waste materials? So everything that I've talked about so far is to reduce further accumulation. There are some lasers that are available that have shown some benefit to reduce drusen, albeit to limited extent. It is certainly a discussion that you can have with your retina specialist. It's called 2RT laser. It's currently not covered by OHIP. And we need more trials to really look at the efficacy of these lasers long-term in reducing these waste materials. You're very welcome.
I have macular degeneration, which I'm getting. Oh, okay. I have macular degeneration. I'm getting shots for it, and I become more longer time between. But I have also cataract, and last time, which was recently, I went to the one that does the surgeries and so on. I've been told there that anytime I want to do it, it's okay. But a friend of mine said that her doctor told her if she can delay it because the macular also, there is more risk that something can go wrong. So better to wait till the macula become more stable and so on before doing the surgery. And another one I'll ask you is the doctor, my doctor said there is 5% chance when doing the cataract surgery that something can go wrong. And I thought this is actually a high number. Thank you.
You're welcome. So excellent question. Thank you for asking that because, one of the other things that changes as we get wiser is our lens, the natural lens gets cloudy. When that lens gets cloudy is what we term cataract. And so a lot of our patients who have macular degenerations will have cataract simultaneously. And so when to do cataract surgery is dependent on the individual patient. So if you're telling me in your particular scenario, your injections are further and further apart, that is a good sign of stability. That means your macular degeneration is stable and we're able to extend you further and further. The goals of care when it comes to macular degeneration is to optimize vision while giving you the fewest number of injections. Nobody wants to have a needle in the eye, let's be honest, right? So if you're stable from that perspective, then the macular degeneration itself does not confer additional risk to cataract surgery. Yes, there is the potential, depending on where you're getting your injection. Our natural lenses are held by, if you want to call it, cable wires. They're suspended by cable wires. When you're getting injections, there's potential for damage to those cable wires. So when we're doing the cataract surgery, it may be a little unstable. Perhaps that was the 5% risk that your doctor had mentioned. I advise all my patients when their macular degeneration is stable, if you have a cataract, go for the cataract surgery. Because your macular degeneration is already putting you at your contrast, the amount of light going in, color, they're all affected. So when you can get your cataract surgery done, those things will be a little bit definitely better. More light can go in, things will be brighter. So certainly I don't know how much you'll see better in terms of just reading, but you'll see that things are brighter for sure.
Just a correction, please. Once that I was told about the 5% chance something can go wrong with cataract surgery, it wasn't referred to macular degeneration at all. It's just a fact. 5% of patients may have some risk of damage. Is that okay?
It's anywhere between, it's not unreasonable. Let me tell you that. We always kind of quote, even when we're doing retinal surgery, I usually say less than 5%, so something can go wrong because of bleeding, infection, retinal detachment, those kinds of things. Typically, the quoted rate is 1 in 2,000, which is actually much less than 5%, right? But you can get rebound inflammation. So it's not even just the physical, like intraoperatively, it could be post-operatively, you can have complications too. So I think that 5% encompasses both intraoperative and post-operative complications. You're welcome.
Hi, I wanted to find out, would it be beneficial for children of people who have macular degeneration to start taking vitamins and stuff in their 40s?
So that's an excellent question. Is there a role for vitamin supplementation before you start anything? So the AREDS2 trial, what it really showed is the benefit of supplementation in patients or in individuals who have intermediate macular degeneration. They didn't show any benefit of the AREDS2 supplementation in subclinical or early dry macular degeneration. What I recommend for patients or people who have children with macular degeneration is the lifestyle factors that you can optimize. So the diet, also physical exercise, putting on more lean body muscle mass is important because it helps to control your diabetes, your blood pressure, your cardiovascular risk factors, right, for heart and stroke, that kind of thing. Trying to get all those pieces as well as you can is going to benefit you long term. And another big piece that we never really talk about as a society is stress reduction. Stress plays such an important role day to day, right? When you're stressed, your cortisol is going through the roof. Your cortisol then drives this fight or flight system, and that can also play a role in inflammation, right? We're all walking around with a lot of inflammation that we don't even think about. So I try to take a holistic approach to treating my patients. So I always talk about, think about the things, what's stressing you day to day? What do you worry about? Try to let go of anything that you can't control. Try to take a more mindful approach. If you can do, mindfulness, meditation, yoga, go for walks in nature, go for walks by water, just to that plays a significant role in your health. And those things will also then help modify your blood pressure, right? You're more relaxed, your blood pressure is not going to be spiking back and forth. That in turn is going to also help your macular degeneration. So optimize your life as best as you can.
Hi, I have a clerical osteoma. It's not the age-related macular degeneration, but I had the same symptoms like bleeding took place. But in the meantime, I was never a smoker, drinker. I eat lots of green vegetables, all those stuff, but still it happened. But it kind of dried out. Now, I'm not having that problem. So I'm just wondering, if there is, is it under your discipline, under your specialty?
It is.
And is there any research coming up?
There's a number of other retinal conditions that will result in bleeding, or what we call choroidal neovascular membrane, including osteomas. Because anything that disrupts the normal anatomy of the retina will put you at a risk of new blood vessels growing, bleeding, and leaking. So the treatment approach is not too far different. If there's bleeding, then you need injections. In essence, what we try to do is stabilize the blood vessels, get them to quiet down, get the fluid to be absorbed, and keep it dry, keep the retina dry. So there's no active research in that particular topic per se, but what it all comes down to, the funneling effect, there is active research in that area.
Just because with this one, there's no bleeding going on, but there's scar tissue.
Correct.
So is there any research
On
to heal those
Yes.
scar tissue? Is there anything going on?
So there is a lot of both preclinical research, we're talking basic sciences, in trying to understand how scar tissue develops, what are the players in scar tissue development, then at which stage can we intervene and slow it down? And the real question is, how do we regenerate tissue, right? Because all of what we do is trying to stop it, stabilize it, not make it worse. But how do we make things regrow from your own tissue? So that's one of my interests in terms of research, and this is, we're not quite there yet to talk about, but I'm very hopeful one day that we'd be able to get your own, because there's pluripotent stem cells within the retina, right? So the key is, how do we get them, how do we stimulate them to grow? And then spread into areas where there's atrophy. So this is future research, and I'm hoping that one day we'll be able to tackle that.
Yes, I'm inquiring about red light therapy. Have you heard of that?
Yes, absolutely. There's more and more literature coming out about red light therapy and how, or what we call photobiomodulation, using light to modulate tissue. So currently, our DRCR network has a study looking specifically at that. The evidence is not yet solidified on what the exact results are going to be, whether it's truly beneficial for everybody, or is it a select group of patient. And right now, I know there are some of my patients who are doing red light therapy. I'm not convinced yet, because I just don't have the evidence to say yay or nay. Certainly something worth exploring. And There's a physiology PhD professor at Stanford who is working a lot on photobiomodulation. If anybody's heard about the Huberman lab, they do a lot of work on the biology and function of retinal cells with respect to not just red light therapy, but as well your circadian rhythm in terms of when you wake up, when you go to bed, if you're viewing light before going to bed, all those they're looking at. So I couldn't comment exactly whether I would recommend red light therapy just yet, but I think in the next couple of years we'll have more solid evidence.
A second question.
Mm-hmm.
Apparently there's going to be a new drug for dry macular coming out.
Correct.
Yes.
There are two drugs, the previous speaker alluded to that. There are two drugs currently FDA approved for dry age-related macular degeneration for those patients who have geographic atrophy. One is through Apellis, the other is through Abbvie, which just, I believe, like just a few weeks ago got FDA approval, both of which are not currently available in Canada. Usually, we lag a year behind when it's approved in the States. So I would say in 2024, we should have approval. Now, one of the important things to keep in mind that he also alluded to is that these drugs slow down the rate of progression of geographic atrophy or thinning of the tissue by about between 20 to 30%. So again, we're not at the point, but absolutely, it's going to make an impact in your preservation of your visual field, right? But it doesn't gain vision or it doesn't regenerate tissue. I think I always like to inform my patients of, because they might say, oh, I'm getting these injections if it's not, like I'm not seeing better. It's not necessarily to see better, it's to maintain what you're seeing right now. So it's important to understand that those are the treatments that are coming in the next year. You're welcome.
The prep that you get before having an injection, it doesn't seem to be standard. Some retina specialists just use numbing drops. Others use the numbing drops plus another injection, which is what I'm getting. And I'm wondering why that is, and if there's any downside to having that injection. Is it for my comfort, or is it so he can get through it quicker?
It's an excellent question. Excellent questions. We all have variability in how we practice. And so it's actually, so the numbing drop is important to anesthetize a topical surface. That's just the drop that goes in. Giving an injection, which what we call subconjunctival lidocaine, or a little bit of freezing underneath the clear tissue over the white part of the eye, is for your comfort. If anything, it actually makes the procedure longer, because once they give that, I like to wait at least a couple of minutes for it to be truly effective. So you don't feel your injections. At least you shouldn't. You shouldn't have any pain with your injections if they're giving that injection, the freezing injection. Sorry? There are no side effects. The biggest side effect with doing that is sometimes you get a little red spot where that freezing was given. It's called a subconjunctival hemorrhage. The way I describe it, it's like a little bruise. It'll go away in a week or two. If it's underneath the eyelids, you don't even see them. It doesn't affect your vision. It doesn't cause pain. It's sometimes noticeable, and say, well, tell them if somebody asks, say you got punched in the eye, you're the tough person, but it doesn't. Now, having said that, the long-term effects of continually getting the freezing, we don't really know. I've seen some patients who have been transferred to my care from another physician who've been getting injections for 10 years with the freezing, and I don't anatomically see any defects in their tissue. Having said that, every individual is different. We can't just assume, a set of guidelines applies to everybody. But the extra freezing, in my opinion, my patients are super happy. So I don't like causing pain to anybody. I want everybody to be happy. So I do what I can to make sure your experience is as pleasant as possible. You're getting a needle in the eye. Like, I don't want to cause pain. That sounds awful.
With your identifying stress and so on and its relationship to wet macular, and as we are all hearing over and over again, the next generation is more stressed, eating fast foods more than we ever ate, because that's all they can do. Are there studies going on to see if the onset of wet macular or dry macular, for that matter, is happening earlier?
That's an excellent question. And as far as I know, there's no current epidemiological study that I'm aware of. But I would predict, based on what we just discussed, that would happen earlier. So anecdotally, I can tell you, just from my limited clinical experience, I do see younger patients coming in with drusen, right? Which I'm like, you're in your 30s. Like, you shouldn't, unless there is a strong genetic predisposition, which there may be, and we're not doing genotyping on every patient who walks through, right? So I do document these things, but it's an excellent actually research idea to see, and then encourage our government. Like, we need to do something, or else in the end it's going to cost you more. Yeah, absolutely, absolutely, yeah. And this is the other part, right? Like, healthcare planning and projection and reducing morbidity and mortality is so important, especially post-COVID now, everybody. Like, the stress of that, which now is going to translate into the next several years, I don't think the right health policies are in place for primary prevention. We're often looking at secondary prevention, and that's not where it's at. For me, it's so important to do primary prevention so then you don't even have to worry about the sequelae, right? And then think about not just the consumption from healthcare dollars in terms of treatment, but loss of productivity as a member of society, right? If they're not able to see, well, you can't contribute to the workforce. There's also like different layers of productivity that's lost and healthcare consumption, but it's another topic.
One last question, and maybe it's not fair to ask this from a doctor. The clinic that I am going to go eventually to do the cataract surgery, I have been told that I can take the regular thing, which is the OHIP, and it's done in the hospital, and that's it. And you get one type of lens, and that's it. But if I pay a hefty amount of money, it will be done in the clinic of the doctor itself with laser-assisted machine. There is such a benefit to that for the amount of money that I will have to pay for each eye?
You're right. So again, this goes back to individualized care. It depends to what degree your retina is affected by the macular degeneration and how much retina is preserved, how much geographic atrophy there is. So in someone, this is my personal preference, this is not to, this is not, again, just like how everybody has their different practice preference with regards to just drops or injections and drops and things like that. In someone who has a retinal issue, I wouldn't recommend doing fancy lenses like multifocals and things like that, because those kinds of lenses will affect your contrast sensitivity. And you already have a condition that's your contrast sensitivity is affected, your color vision is affected. So don't do things that's going to further impair those functions. I would recommend an aspheric lens, so a little bit of an upgrade from the OHIP. OHIP covers spherical lenses.
I'm sorry, it's the same lens people use, like using in the hospital.
Oh,
Different.
yeah. So, it is a very tricky question. Standard cataract surgery is sufficient with an aspheric lens. Yeah.
So the laser doesn't assist the doctor?
The laser does assist them, but how much benefit are you gaining? That's the question. So that's what you need to ask your doctor.
Thank you.
You're welcome.
I've been having injections for a year and a half, and right now I'm on every 6 months. Is it likely that I will suddenly lose some sight or go completely blind? I know that with the macular it can be sudden jumps.
There can be. There's always the risk. So what some studies have shown is that when I talk to patients, I tell them, hey, this is a lifetime thing. Our goal is to give you an injection. If we can get you out to every 3 to 4 months, that's great. You come in 3 times a year, maybe 4 times a year for an injection. That's it. There are studies that show about 20 to 25% of patients can successfully come off injection and stay stable. Now, could you have a rebleed? That's like a big bleed. Absolutely. There's always a risk where now things could be worse off than before. Because when you have a big bleed, that's harder to treat as opposed to maintenance, right? You're maintaining stability. So there's no easy way of saying, no, you won't ever lose vision. That's, it's hard to know. It's hard to know based on your genetics and what the retina looks like. There's always a very small possibility. This is why, things like when we talked about the home OCT monitoring, it's very useful. It can detect early subtle changes so then prevent that big bleed from happening.
I'm sorry, I'm not familiar with what you just talked about.
So the previous speaker talked about, when you go into the doctor's office, they take scans. They take a scan of your retina to see if there's fluid, bleeding, all those things.
Yeah.
Now they've developed something where you can do that from home.
Oh.
Yes. So that's the next phase of providing care so that you don't have to keep going into the doctor's office. You're at home, you sit in front, you can hear me, right? You sit in front of a machine, it takes an image, it automatically sends it to the doctor's office, and they can read it.
Okay.
And there's AI algorithms, programs to read it, so we can detect earlier if you're gonna have a bleed or fluid buildup.
Thank you.
You're welcome.
Hello, 2 questions. One,
Yes.
I've had dry macular for 6 years and no deterioration, but I was told not to take the Areds too, that it wouldn't make any difference to stabilize it.
So if it also depends on what, there's different stages of dry macular degeneration. So if you've had, it also depends on the type of drusen, where the drusen is in the retina. There's hard drusen, soft drusen, and each one of these variables plays a different role in the progression of the macular degeneration. So perhaps you have some positive contributing factors that are preventing progression, so you may not benefit. As I said, the benefit of the AREDS 2 formulation is for intermediate or more of the dry macular degeneration. So if you're subclinical or early, you may not benefit.
Okay. Well, I've been already 6 years into it, So,
But if you're 6 years into it and you're stable over the 6 years, as in like what you presented with is how you are now, that's excellent, because it just shows that there isn't any natural progression.
okay, so should I take these drugs or these vitamins or not?
So I would have to examine your retina to really comment on that. But if somebody is following you and they're telling you that you don't need it and you haven't changed from year 1 to year 6, then you don't need to.
Okay. Second question, I go for acupuncture treatment
Yes.
for the last year to try and reduce the rate of degradation. What's your comment about acupuncture?
Reduce the rate of degradation of...
My sight.
Interesting. I have heard about this before. So I'm not well versed. I have to preface the conversation with that. I do believe there is a role for, as I said, I take a holistic approach to how I practice. I think there's a role for alternative modes and therapies. And I think the power of the mind is incredible. So if you believe that this is making a positive impact, I would say continue to do so. As long as there are no negative, side effects and you're feeling great, absolutely. Because there's a concept of, the concept of placebo, right? It's a true effect. If you believe that something is working for you, there's a 30 to 40%, roughly 30, placebo effect on treatments. Why? Because we're believing somebody is giving us a treatment and it is working. So think about the power of the mind, right? So I haven't read literature on it, but yeah, absolutely.
Okay, I think we have time for one more question. I'll let you in the back first. I'm gonna come to you.
I'll stick around, so I'm more than happy to we'll chat.
About the Amsler grid, I was just,
Yes.
What are your thoughts on maintenance and sort of checking in with the Amsler grid?
I love the Amsler grid. The reason is because I like to empower my patients. Any changes they notice, I want to know. So every patient that I see, I give them an Amsler grid that's magnetic, and I tell them, put it on your fridge. You know where it is. Whenever randomly you're going to grab something, it's like quick, boom, boom. And you're like, oh, I see a little new spot. Should I go check it out? Just come see me. It's, yeah.
Ours aren't magnetic, but in everyone's bag today, you should have an Amsler grid, so you can use that tool.
Yes.
Do you mind, maybe if people don't know what it is, just talking a little bit about that?
Absolutely. So the Amsler grid, I don't know how many what the actual dimensions are. Basically, it's a checkered box, right, with a central dot that allows you to focus on the central monocularly, so one eye at a time, right? You're looking at this dot, and what allows you to check one eye at a time to see if there's any spaces. It focuses within your macula, the area where macular degeneration is affected, to see what's baseline. So when you look at it and you focus on the black dot, if all the lines and boxes are straight, that's normal. That's what you should see. But if you're starting to see a little wiggly line in a corner or a spot that's missing in your field of vision, then you should go in to see your eye specialist, whether you're optometrist, ophthalmologist, retina specialist, somebody, because you're now noticing something that's different from what is expected. Then you look at the other eye, same thing. So this could be because of drusen, pigment changes, bleeding, fluid, for various reasons. If it's a treatable condition, then that means you're gonna pick it up early, you're gonna treat it early, you're gonna preserve vision longer. So it's a good way to self-monitor at home. It's like a, thank you so much. So this is for anyone, this is so tiny, I need to project it much bigger on here. But this is like the poor man's version of OCT at home, if you want to think about it.
And everyone should have one in their bag. It's sort of, I don't know, what's the dimensions of that? I'm so bad at this. Maybe like 8 inches by 4 inches, maybe, or 3 inches in your
It's
bag.
even
It's
smaller
like
than that.
Even
It's,
smaller than that, on like
yeah.
a cardstock.
It's almost like 10 centimeters by 10 centimeters, I want to say,
Oh, like
roughly.
the
It's a
actual
cube.
grid, yeah.
Yeah.
I meant the paper itself. Like
Oh,
in your bag
yes.
For it. Yeah, it's like a cardstock.
Ta-da.
Yeah, put that one on. You can put that one on the fridge. Okay, we're gonna have one last question.
When you talked about the power of positive thinking even, and my one concern about doing an OCT at home repeatedly is the bond between yourself and your practicing physician is, to me, the ultimate bond of establishing a positive attitude.
Mm-hmm.
If you walk in and the physician takes that care and is positive with you, and you feel they have your interests at heart, you go home and you forget the diagnosis and you live your life fully.
Mm-hmm.
And I would hate to see that bond eroded, because I think it's critical in all of us, how we look at our eyes and deterioration of sight.
You're absolutely right. There's something to be said about a therapeutic bond, because it does help. So the concept of the home monitoring OCT is for patients where maybe now their interval treatments are far out. So in the interim, we can capture information so that we can pick up things earlier and then not have somebody come 4 or 6 months later and then have a bleed. It's more for that. It's to try to optimize preservation of vision. It's not to replace this physical. We're humans, we need human contact, right? Like, and there's, yeah, the world is changing, but I'm still, call me old school, but I think it's so important for us to sit and talk and have that interaction.
I think we're gonna have to call it there, but what a nice note to end on. Thank you so much, Dr. Sivachandran.
Thank you. And thank you so much for having me. This has been an absolute pleasure. Thank you, guys.